If you've just been told that you have thyroid cancer, I know exactly what you're feeling. And there's probably terror and panic and the question if you're going to be around for your kids. I know it because I'm a high volume thyroid surgeon. I've helped thousands of patients with their thyroid problems over the years, specifically thyroid cancer. Today's podcast is to separate fact from fiction and help you understand what you need to know and what you need to be talking to your surgeon about and your doctor about and what your prognosis is. So today on Total Thyroid, let's dive deep into thyroid cancer. So I see patients, and I have for the last decade of my life, who have thyroid cancer every single week. And I started at the Cleveland Clinic, and then I went to Johns Hopkins, where I led the multidisciplinary thyroid tumor board. And now I'm at the Russell Center for Endocrine Health. And every single week, these patients come in, and I've done surgery on thousands of them, and I've got all of this personal follow-up. And that's what we're going to use to talk to you, as well as the guidelines from the American Thyroid Association, where I am a member of the Guidelines and Statements Committee, where we look at all of the best available evidence and we come up with a plan for you so that you know what is likely to happen and so that you can have the best outcome. And in today's episode, we are going to go into what thyroid cancer is and what it's not. Thyroid cancer is different from other types of cancer, and it's important that you know that as you're kind of going through everything. We're also going to talk about why the diagnosis sometimes is scarier than the actual disease. We're going to talk about different types of thyroid cancer, what they actually mean, when you should worry, when you can breathe, and what questions you need to ask your doctor. So that's our game plan. That's our rubric for today. Hang on, and thanks for joining us at Total Thyroid. So here's the big misconception. So there's a lot of conversation among doctors about whether or not we should call most thyroid cancer cancer. And the reason that we question that is because thyroid cancer has a very good prognosis. And in fact, for the average person with thyroid cancer, the likelihood of dying of thyroid cancer is probably less than that of dying in a car accident for a lot of the patients that I see. And that depends a lot on your tumor, and that's what we're going to spend time talking about. But thyroid cancer has a really good prognosis. And when we say the C word, all of a sudden patients start to get anxious and they start to think that they have to move quickly. And our job as surgeons and as doctors, and hopefully what I think my job is with this podcast, is to help you breathe, plan appropriately, get the best care so that you can have the best outcome with the least likelihood of compromising your overall quality of life. One thing is that I think it's important to look at some literature. So when you look at other countries, and even in the United States, we have had a significant increase in the number of diagnoses of thyroid cancer over the last 20 or 30 years. And over that time, the amount of people who have died from thyroid cancer has stayed almost stable. And so what that tells you is that we are treating more and more patients with thyroid cancer, but the same number of patients are dying of thyroid cancer. And so to some degree, what we're probably seeing is that not everybody who has thyroid cancer needs to have really aggressive treatment. And so we are trying to scale back a little bit how much treatment we do. But at the same time, there are some cancers that are more of a risk. And those are the ones that we also want to talk about. What do you need to be thinking about? What should be on your list of what makes you actually anxious and worried? The most common type of thyroid cancer is papillary thyroid cancer. That's about 85 to 90% of all thyroid cancers. Another name for that is well-differentiated thyroid cancer. And that means that the cells, when you look at them under a microscope, they look like thyroid cells. And so the reason that this type of cancer has such a good prognosis is because these cells divide very slowly. And they might be a little bit more likely to spread than some other types of cancer, but because they grow so slowly, they give us lots of time to treat them or just watch them until we need to treat them. And so for that reason, this type of cancer has the best prognosis. Follicular thyroid cancer is also a well-differentiated thyroid cancer because it still looks like cells from a thyroid under a microscope. It is still very treatable. It spreads a little bit differently because follicular thyroid cancer spreads hematogenously, which just means that it spreads through your blood. For that reason, instead of going to the lymph nodes close by your thyroid, it's more likely that follicular thyroid cancer will go to your lungs if it's going to spread anywhere. Now, your lungs are a little bit harder for us to treat than lymph nodes because lymph nodes, we can always take them out. Whereas your lungs, of course, you need those. And so follicular cancer has a very slightly worse prognosis than papillary thyroid cancer, but still the odds are very good that you're going to live a long and very healthy life if you have follicular thyroid cancer. Oncocytic thyroid cancer was previously known as Hürthle cell cancer. It's another well-differentiated thyroid cancer that tends to grow slowly. I don't like this one because it keeps coming back. And so even though the prognosis is overall pretty good, this is the type of cancer that can cause problems just because it likes to keep coming back. Then once you get through with the well-differentiated thyroid cancers, then you start to talk about the poorly differentiated thyroid cancers. Poorly differentiated thyroid cancers are cancers that when you look at it under a microscope, it doesn't necessarily look exactly like a thyroid cell. And so for that reason, we can't tell, it hasn't differentiated. It just kind of looks like a cell, like an abnormal cell instead of a thyroid cell. And so it's called poorly differentiated. And because these cells are less healthy, they grow a little bit faster, they cause more problems, they're more likely to spread. Poorly differentiated thyroid cancer does have a worse prognosis. And then anaplastic thyroid cancer, kind of all of these cancers happen on a continuum. You start off a lot of times with papillary, and then you'll kind of march down the chain. Now you don't get follicular and oncocytic cell, but you can go from papillary to poorly differentiated to anaplastic. Anaplastic is the thyroid cancer with a worse prognosis. It can grow very quickly and does like to spread very quickly. There are some good targeted therapies that can work very well against this. And I love these therapies because these are new even since my career started independently. And so I love the fact that I can remember some patients that we treated that now I know would do so well with some of the targeted therapies that we have. And I love knowing that my new patients that come in now have access to these therapies that we didn't have even just a decade ago. So hard disease, but there's a shimmer of light if you find out that you have anaplastic thyroid cancer. And then the last one that we'll talk about is medullary thyroid cancer. Medullary thyroid cancer is a totally different type of thyroid cancer. It actually comes from the chief cells, which are inside of the thyroid, but not necessarily, they don't make thyroid hormone. But this type of thyroid cancer, it tends to spread also to different parts of the body. It can also go through the lymph nodes. We know that you have medullary thyroid cancer if your calcitonin or your carcinoembryonic antigen, CEA, levels are elevated. If those levels are elevated, then we look for metastatic thyroid cancer, metastatic medullary thyroid cancer, and that can be problematic. This is how you're trying to think about your different type of thyroid cancer. Again, papillary, follicular, oncocytic, poorly differentiated, anaplastic, or medullary. All slightly different prognosis. The good news is the less common cancers are the ones that have the worst prognosis. The more common the cancer, usually the better the prognosis, even if you do have metastatic disease. So things to think about as we're going through there. It is all on a continuum. And so most papillary thyroid cancer has a really good prognosis, but it does go down this continuum. And there are some that start to behave more aggressively. And that's really when we talk to you about whether or not we should intervene on kind of the cancers with a better prognosis, what we're trying to do is figure out, is this the type of cancer that we want to intervene now so that it doesn't become worse later? And that's the conversation that you should be having with your doctor when you're trying to figure out what is the best treatment for you. The size of the tumor actually really matters. And so really small thyroid cancers have a really good prognosis almost always. And to some degree, it doesn't even matter what type of thyroid cancer is. If we find it early enough and it's small, you have options and we can fix it almost always. And of course, small cancers are defined as those that are less than 1 to 2 centimeters. Larger cancers are usually over 2 centimeters, and the guidelines kind of talk about the 4 centimeter marker. Somewhere between 2 to 4 centimeters, the cancer starts to sometimes behave a little bit more aggressively, and that's what we're trying to prevent. I've operated on thousands of these tumors from all of the different sizes, and in general, the prognosis is better than 98% survival if we take all comers who walk in the door with thyroid cancer. So that's a good thing to think about. Depending on your age, thyroid cancer is a little bit different when we talk about stages. So the staging of thyroid cancer is different because if you have a thyroid cancer and you're younger than 55 years old, you can only be stage 1 or stage 2 if you have papillary thyroid cancer. And it, excuse me, and it really is defined on whether or not it has spread to another part of your body. If it hasn't spread to another part of your body, then you have stage 1 thyroid cancer. And if it has spread to another part of your body, then you have stage 2 thyroid cancer. That doesn't include lymph nodes. If you have spread to lymph nodes, you still have stage 1 thyroid cancer if you're younger than 55 years old. So that's good to think about. With anaplastic thyroid cancer, because it's so advanced, it does start off as stage 4 thyroid cancer, stage 4 anaplastic cancer every single time. So again, we treat that one with a lot of respect. When cancer starts to spread to other parts of your body and you're older, if you're over 55 years old, then we rely on different things like lymph node involvement or spread to other parts of your body, or whether or not we can take the cancer out surgically. And those are the things that we use to define whether or not you're stage 1, stage 2, stage 3, or stage 4. So those are the different things that we think about. So again, kind of going back through your specific prognosis, the size of your tumor, probably the most important thing. Your age at the time that you get diagnosed, younger is usually better. Whether or not we can take it out, whether or not it has spread to the lymph nodes, whether or not it has spread to other parts of your body. And then to a lesser degree, we rely on genetic markers or molecular markers, tumor markers about what that cancer actually is doing. So things like BRAF, you're going to hear about that, or RAS, or different mutations can make a cancer more or less aggressive. And so those are things that if you talk to a high volume thyroid surgeon, they're going to kind of go over what your specific markers are and what it says about your tumor. We don't always need those markers. So if you haven't had them done, that doesn't mean you have to rush out and get another biopsy to do them, unless you have anaplastic. If you have anaplastic, then yes, we usually want that guidance. But for other people, for most people, we don't necessarily need those tumor markers to know what we do, and we can get them on the back end after surgery as needed, depending on what we see. Okay, so here's the here's the treatment options about what we could do. The first thing to think about is that there are so many new thyroid cancers and the same number of people dying, and that tells you that some patients can choose not to have surgery. We call that active surveillance. Whether or not active surveillance is right for you depends a little bit on your age. We know that younger people, the cancer grows more, it's more likely to spread, and so younger people might not be as good of candidates for active surveillance. Older people, the tumor tends to be a little bit more stable if we find it when it's small. Also, active surveillance is only appropriate for people with really small tumors. We don't want to be doing active surveillance if we have a high likelihood that the cancer is actively spreading to other parts of your body. Other things that we think about are where your tumor is. Is it close to your voice box? Is it close to the nerves? Is it close to something critical that if it grows even just a little bit, it's going to cause problems or make surgery very challenging? Active surveillance is not the same as doing nothing. It actually means you're going to need regular ultrasounds. And so another thing, if you are going to have a hard time having follow-up for decades afterwards, probably active surveillance might not be the right choice for you. So those are things that you need to be thinking about. It's very common in Japan to do active surveillance. Other parts of the world, it's not quite as common. For surgery, most of the time for small tumors, it is best to only take out half of your thyroid. We call that a hemithyroidectomy or a thyroid lobectomy. And the reason that that's best is because it's adequate for your cancer. It is a safer surgery, and most patients don't have to take thyroid hormone if they still have half of their thyroid. And so for most people, the idea of only taking out half of their thyroid is the right thing to do for a small thyroid cancer. Once the cancer gets over 4 centimeters, probably you should be thinking about taking out the whole thing so that you can have radioactive iodine if needed. Somewhere between 2 to 4 centimeters, you should have a conversation with your doctor about whether a half of your thyroid or a whole thyroidectomy is appropriate. Recovery time, for most people, within a couple of weeks, you're feeling pretty good, kind of 95% back to normal. A lot of patients, we do surgery on Wednesday, and by Monday, they're back at work if they have a desk job. But you should plan on a couple of weeks of recovery. I don't like my patients to do super strenuous activity like exercising to break a sweat for at least a couple of weeks after surgery. We want you just to be cautious. We don't want you to lift things for the way more than about a gallon of milk in the interim. Just be cautious. Give yourself time to recover. You're going to have fatigue from general anesthesia. These are things that are normal, and they get better. I tell my patients that a little bit of voice changes are expected because we put a breathing tube in. And then for the first couple of months afterwards, some scratchiness, especially when you're singing, is going to be noticed just because of the fact that you've got a lot of inflammation right next to your voice box. So even if surgery goes great, you might notice that your voice isn't perfect, even if other people around you feel like your voice is pretty good. So those are things to think about. When do you need radioactive iodine? Most people don't need radioactive iodine. And in fact, we're doing less and less radioactive iodine for thyroid cancer now. Usually it only works for people with papillary or maybe follicular or even oncocytic cell thyroid cancer. But if you don't have one of those, we don't generally tend to use radioactive iodine. We want to use the lowest dose that's good for you because we do know that radioactive iodine can have downstream effects and even cause other cancers in a small percentage of people. So it's not always right for everybody, and we want to use a small dose if you need it, but it can help some patients and can make it easier to follow you up afterwards. Usually just one treatment, small pill, you take it, stay away from very small people for a little while, but it's pretty well tolerated. Talk to your doctor about whether or not you need it. And then after surgery, the next step is how do we follow you to make sure that your cancer doesn't come back? You're going to do ultrasounds, you're going to do lab tests, specifically looking at your thyroglobulin or your thyroglobulin antibodies. And then we're going to be watching those over time to make sure that your levels stay the same or even get better. And we're watching to make sure that we don't see signs of cancer coming back. Sometimes we'll do something that's called a whole body scan, which just looks to see if the cancer has spread to any other part of your body. So that's something that you might also have. And usually we do all of those things, and even radioactive iodine, we kind of are looking within a 6-month after surgery sort of timeline is what we're looking for. But that's not set in stone, and we have a little bit more flexibility than we do with a lot of other cancers, again, because thyroid cancer usually grows pretty slowly. You also, if you need thyroid hormone, we usually would determine that about 6 weeks after surgery if you still have half of your thyroid in. Okay, so things to ask your doctor. If you just found out that you have thyroid cancer, what do you want to ask your doctor, specifically your surgeon? You're going to want to ask, first of all, how many surgeries do they do? In your surgeon's hands, how likely is it that you'll have a permanent voice change? How likely is it that you're going to have low calcium levels? How likely is it that you're going to need to spend the night in the hospital? Those are the questions that you want to ask your doctor to try and figure out all of those different things. I think that's the most important question. Then you're going to ask, like, what is the stage of my cancer? Do you think that it has spread? Stage. So when you talk about stage, I will tell patients, because the stage is just stage 1 and stage 2 for most patients, I am a little bit less reliant on stage than just kind of telling you more organically, like granular level, like what your tumor is doing. So it's confined to your thyroid, or I think it has spread a little bit to your lymph nodes. Those are things you also want to find out if you need a lymph node biopsy. Next, you want to talk about active surveillance, if that's an option for you. Usually that's just going to be for the smallest tumors, but at least it's good to have that conversation because you're going through everything. Then continuing on, let's talk a little bit about, do I need half of my thyroid taken out or my entire thyroid taken out? And that that will affect whether or not you need thyroid hormone for the rest of your life. And then also you want to talk about like follow-up plans. Who are you going to be following up with? Will it be your surgeon? Will it be your endocrinologist? And what that looks like, how often you'll get ultrasounds, all the rest of that. Those are things, a few good questions to ask your doctor. So here's the bottom line. You found out you have thyroid cancer, you're stressed, you're anxious. Hopefully now you know most thyroid cancer has a really good prognosis and you've got lots of different options. I didn't even talk today about radiofrequency ablation, that for some patients, especially those who are eligible for active surveillance, you can often do a non-surgical therapy called radiofrequency ablation, where we just put a needle in and we kill the cancer right where it's at. By just killing the cancer right where it is, we allow the rest of your thyroid to be healthy, and we don't necessarily expect that you would need to take thyroid hormone afterwards. So it's nice because it's very localized. It's a very relatively low risk depending on where your tumor is, and if you find somebody who does a lot of RFA for thyroid cancer. So those are things that you might be thinking about. Other things, thyroid cancer is very slow growing, very treatable. You have time to make good decisions. So plan, plot, find the right surgeon, find the right situation, get yourself taken care of, and expect that you're going to do well. And you want to find a surgeon who's not just like a general surgeon or a general ENT. You want to find somebody who really focuses and specializes in thyroid surgery. The American Thyroid Association is a great place. Their website has good information about this. Also, you can look for the focused practice designation certification from the American Board of Otolaryngology Head and Neck Surgery is another place that can tell you that your surgeon focuses a lot on thyroid surgery. Those things can help you. Finally, just remember, you are not powerless. You actually determine a lot about what ends up happening with your long-term prognosis. Finding the right surgeon, finding the right team, getting the right treatment plan put together, you actually can make sure that you do really well, regardless of whether you need surgery or not. So hopefully these things help. If I can help, please reach out to us directly at the Russell Center. We're always happy to help, no matter how advanced your specific tumor is or what necessarily you need to have happen. We're used to a lot of thyroid cancer. We've got a lot of experience with it, and we really care about making sure you've got the best treatment. So anyways, please reach out to us if we can help, and best of luck to you on your journey. Hopefully this helps because you've got this.